Hey, Omis, welcome back to the I Believe podcast. Today we have two guests who are here to highlight just what's new in the treatments for ocular melanoma, what you should know going into treatment if you're a new patient. And we have two guests, Dr. Funchain, a uveal melanoma medical oncologist at Stanford, and Dr. Mruthyunjaya, who you guys have seen lots of things from him. We are so grateful to him coming back again and bringing Dr. Funchain along for the ride. And he is from the Byers Eye Institute at Stanford. So we're going to be chatting about neoadjuvant and adjuvant therapies in uveal melanoma. Don't worry, we're going to break these down for you in case you don't know what those words mean. So just to start, Dr. M, can you just tell us what is a neoadjuvant therapy?
Thanks, Nate. Thanks for having us on board today and talking about this very new, exciting, but probably a foreign concept for many of our viewers. So by definition, neoadjuvant therapy is a treatment that's given as the first step to try to shrink a tumor within the body in advance of a more defining therapy that would follow, such as laser or radiation, or more likely surgery. So the concept is that you have a tumor in the eye, say an ocular melanoma. If you could give that patient either a systemic therapy like chemotherapy or direct therapy right to the eye, for example, and that causes that tumor to shrink, the amount of secondary treatment that's required, say the extent of surgery or the type of radiation or the amount of radiation, would potentially be less. But the other advantage is that if in fact that tumor is shrinking with this pre-definitive surgery approach, then there may be a role that neoadjuvant medication might be playing a role in the rest of the body as well. And that might get into a way that by response or showing response, it may actually have a longer term benefit than just making that initial eye-related therapy more successful or easier to manage. So neoadjuvant means treatment before definitive surgery or radiation, usually with some form of a specialized chemotherapy.
Okay. Well, and you kind of alluded right into the adjuvant therapy as you kind of hinted at what we could use neoadjuvant for later, right? If it is successful in shrinking a primary tumor, then we could get into the use of it adjuvantly. So, Dr. Funchain, do you want to tell us a little more about an adjuvant therapy? What does that mean?
Yeah, so an adjuvant, you can think of an adjuvant as a helper, right? So if you have surgery or radiation, that's what we call sort of the definitive therapy. That's the thing that's supposed to take everything out. But what we know is that there's not a perfect guarantee that everything is out. And that is usually because there's melanoma sometimes in the eye, less commonly, but that there's melanoma somewhere else, like in the liver, right? And that would show up months to years later. And the whole idea for adjuvant is that you take a therapy. Typically, it's what we call a systemic therapy, so a therapy that goes all through the body. And then what that's going to do is try to clean up any cells that have wandered somewhere else, wandered off to the liver or lung or somewhere. And so we actually have used adjuvant therapy in a lot of cancers. I think people most commonly think about people getting chemotherapy after breast cancer. So you can have the surgery and even radiation for breast cancer, but for some people, when the risk is high enough, you follow it up with chemotherapy. So adjuvant, we haven't really used for uveal melanoma, but we're starting to think about drugs that might make sense in that place.
Okay, so we're mostly talking, I'm assuming, you guys in our audience, you guys have probably had treatment for your uveal melanoma. So let's just kind of, to make sure that we don't have anybody tuning out and go like, oh, this isn't for me. Why is this important? Even if you've already been treated, say 5, 10 years ago, months ago, why is this important for patients to pay attention to now?
So, what we found, I think one of the really interesting things about both neoadjuvant and adjuvant therapy is if we find signal in either of these areas, then what we've done is said, look, this drug works in a smaller setting, right? In either it's just melanoma just in the eye or just a few cells somewhere else. If we find that there's signal, so if these trials come up to be positive, which means there's an effect, like a good effect, a positive effect. If there is an effect, then that starts telling us that these drugs might be useful in any setting, right, might be useful. Should the cancer come back in the future, maybe these drugs are something we should think a lot harder about or combine with other things. So seeing a signal in these settings and because there are, you know, way fewer treatments than we'd like to have in all settings, any signal anywhere, we will take across the spectrum.
To echo that, that's a really great way to think of it, that even if you've already been treated, it doesn't mean that that information couldn't be beneficial to you, if not today, into the future. And a couple of things that, kind of come into play, everyone always wants to know about, are there clinical trials or options that are available? And if we didn't have this information available to us in either the neoadjuvant or even adjuvant setting, then it's hard for companies that are like making these blockbuster drugs to even think about its utility for us. So the more options that our patients are involved with in earlier clinical trials really makes the entire ecosystem of what's going to be available for our patients much broader and much richer. And the other area that many people may have heard of neoadjuvant and adjuvant treatment is in skin melanoma. So we tell everybody uveal and skin are two different distant cousins, but we do take a lot of information and knowledge from Dr. Funchain's colleagues and herself, who have done a lot of work with metastatic cutaneous melanoma, so skin melanomas that have spread. And there's some, very compelling data using, say, checkpoint inhibitors, which we tend, not to use as like the absolute perfect way, and Pauline can correct me, to treat, metastatic uveal melanomas. They have a role in it, but man, in skin melanoma, it really seems to make a difference that if you treat someone up front with this powerful immunotherapy, and then take them to surgery and then follow them up with that same medicine afterwards, like it can make a really big difference in their survival. Pauline, is that even close to true or?
Well, that's totally true. So we've essentially taken, because as a melanoma oncologist, you treat skin, you treat mucosal, you treat uveal melanoma. We have wholesale taken anything that works in skin and moved it along to mucosal and uveal, because while there are huge differences in biology between all of these melanomas, at the base, they are all melanoma, right? So there are some commonalities. And I think we haven't found that things in cutaneous melanoma. So this is the hard part, right? As a patient, when you read about melanoma, you'll often read about things that pertain to skin melanoma, and you really hope that it applies to you. Unfortunately, they don't apply across the board. However, I think we have learned a lot. There are some efficacy signals in the other melanomas. And I think what we need to find in the non-skin melanomas, in uveal and mucosal, is just tweaking what we've done in skin and tweaking it the right way. So we haven't found the magic tweaks, but we found some decent tweaks. And I think we'll find more. But it's a great place to start, because honestly, if we look at 10 years ago, we didn't have a single FDA approved drug, and now we do. And not only, and just as you said, now that we've had that FDA approved drug for uveal melanoma, that has been a watershed for companies to get interested in this space. And that, I just, so I just gave a talk on uveal melanoma, and the joke was like, a couple of years ago, this was always the shortest talk if you were giving the uveal melanoma talk. And I had so much in that talk, I could not fit it all in. That's the magic of having just one FDA approval. It just breaks open the science behind trying to get this cancer off our radar.
Danae, another area that we need to also touch when we talk about neoadjuvant therapies. So to be clear, there are no approved neoadjuvant therapies for our patients with uveal melanoma today, in March of 2025. However, if that neoadjuvant strategy bears fruit, there could be a couple of really good things that can happen. First, as we all know, there are side effects from the treatments that we have for treating ocular melanoma, though they are great. Radiation therapy, surgery for eye removal, very, very high rates of local tumor control. We can control the cancer in the eye. Now, imagine if you could treat a patient with radiation that you know could have side effects. And Danae, you've talked about radiation retinopathy and other side effects on your podcast before. We know that there are still no like approved therapies for that. Imagine if you could take a tumor, treat the patient before radiation with chemotherapy that shrinks that tumor by, let's say, half, right? It makes intuitive sense that maybe you'd have to use much less radiation to treat that same tumor with the same great outcome in terms of the ability to control the tumor within the eye. But if you're using, say, let's just say 50% less radiation, you might guess that some of those side effects will be less. I'm not saying it'll be 50% less, but maybe it is. We don't quite know that. Or a patient who has a very large tumor that we know that enucleation would be the recommended treatment. If there's an effective neoadjuvant treatment, what if we took that very large tumor and made it small enough that then radiation could be used? Yes, it's still a lot of radiation and there's side effects, but we might be able to save some eyes in that process. So there's a local benefit if we have good neoadjuvant strategies. And then the secondary effect is what Pauline's talking about, is that maybe then those cells that have potentially left the eye and are floating around that we can't detect on a MRI or a CAT scan, maybe those get attacked also by that same medicine. So we're looking at the eye, but the medicine is surveying the whole body. And maybe that one rogue cell gets eliminated in the process of prepping the eye for, definitive surgery with maybe less side effect. Now, this is all very theoretical, but wow, the eye is such an important organ, right? It's so much more complicated than saying I'm taking a piece of my liver out and it'll regenerate. That doesn't happen in the eye. So, with these brain functioning tissues like the eye, any way that we could, reduce side effect, I think that's a plus.
Yeah, no, it's definitely a plus. I mean, speaking as someone who ended up with enough radiation damage to her eye that I had to have it removed eventually, like not because the tumor wasn't, treated adequately. It was just because the radiation damage was so bad that the eye was no longer considered healthy to keep in my body. And I've heard of people, currently who are on these neoadjuvant trials at least. So that was what I was going to ask you, Dr. M, is, we don't have anything approved in the space. You're right. But do we have anything that is currently actively recruiting for, clinical trials in the neoadjuvant setting? And if so, what are those?
Yeah, so we've been really fortunate when Dr. Funchain joined us here at Stanford that she was very aggressive in bringing the latest clinical trials that really have sound biologic functioning. So we are working with a company called IDEA, who have brought forth a neoadjuvant study in uveal melanoma using a drug called darovasertib, or Daro for short. This is a drug that blocks a particular protein that we find active in uveal melanoma called, it's a protein kinase C inhibitor. Really smart science that has to put this together. And it's been used in patients that have metastatic melanoma. And then they found, incidentally, some patients, when they examined their eyes, their ocular melanoma got smaller. So they have set up a clinical trial now that's in the phase 2, a part of the approval cycle. So they have 2 arms to this study. One is to give this medication prior to patients who might be undergoing enucleation to see if a percentage of those wouldn't need enucleation and could be treated with radiation and try to save their eye up front. And then a second arm, which I think is very compelling, is patients that are getting radiation treatment as planned therapy. They receive this neoadjuvant therapy up front, and then to see if that tumor shrinks so that the radiation dosing is decreased. Dr. Funchain's the principal investigator of the trial here at Stanford, and I think she probably can tell you even a little bit more about it.
Yeah, that'd be awesome. Dr. Funchain, do you want to tell us a little more?
Yeah, I think a couple of things about the trial. So there were some preliminary results that were very promising. So one of the earliest patients was somebody who would have needed their eye taken out to get an enucleation, and they were able to have such shrinkage with this neoadjuvant treatment that they were able to save their eye and do radiation, right? We don't know all of the consequences of this, but that is, we know that being able to save an eye when it's possible really means a lot to patients, right? So this is a really meaningful response. And we have seen since this trial has gone on from phase 1 to phase 2 and has a much larger number of people who are treated, that person is by far not the only one. There are some very promising results about in terms of patients being able to save their eyes, and then others who have had their radiation field reduced. Now, does it work for everyone? So far, it's not a perfect magic bullet, but it's really promising. And the drug itself is decently tolerable. I think we've definitely seen combinations that have more toxicity than this. So right now we are seeing some good results. This trial is still ongoing, but there is movement to try to make this bigger and potentially go for an FDA approval, which I think is very reasonable given what we've seen so far.
Danae, this is also paradigm shifting for us, right?
Yeah,
Because
no, it's
if you
huge.
if you think about it, the ocular oncologist sees the patient, we decide on the treatment, we might do a biopsy, we might determine, whether someone is high risk or low risk, and then they meet Dr. Funchain after that, right? So surgery is done, eye is removed, radiation is produced, and then she's in charge of making sure that the screening is done properly, early tumors are caught, and treatment is initiated. This is an excellent opportunity for the all members of the team, the medical oncologist, the radiation oncologist, and the ocular oncologist to meet up front, right? So we're taking a team approach to addressing a small thing in the eye, but more importantly, preserving the body. And so I think that's a real great intersection that I think we're all enjoying, that we get to now hear some of the vast experience that our medical oncologists have had with neoadjuvant therapy that ocular oncology really hasn't, with the exception of when we treat our babies with retinoblastoma, which is an eye tumor that occurs in children. We've been giving chemotherapy to them up front in a neoadjuvant setting, for now several decades. I think the challenge in uveal melanoma has been that we haven't had the right drugs, we haven't had the right approach, and we haven't had enough interest. It's like perfect timing. Like we have a drug that seems promising with a team that's now bringing it together, and then now this community of medical and ocular oncologists and radiation oncologists that are trying to move this forward.
I'll just add one quick thing Dr. Mruthyunjaya makes a fantastic point in that in medical oncology, not just uveal melanoma, not just cutaneous melanoma, but in other cancers, we have used neoadjuvant approaches, so doing treatment before the definitive surgery or radiation. And in many cases, what we find is that if you start that early when there's less cancer to deal with, right? That's sort of the earliest time that you can put something systemic, something that goes all through the body, up front when there's less disease, you can actually not just improve what's going on in the eye and treatments for the eye, but you can then improve overall survival. So, all the potentially getting rid of the cells outside of the eye. And so in many cases, you're doing two things. And we've kind of mentioned this before, but I just want to emphasize that this is a possibility. We haven't seen the data yet from this trial, but we're really hopeful that when you start early with fewer cells, it's easier to knock everything out if there's stuff outside of the eye.
Yeah, I mean, I feel like that theory makes sense when you think about the idea that, okay, the primary eye is the source of the cancer, or the primary tumor in the eye, that's the original source, but then there's these potential micrometastatic cells that at some point have gotten out before the eye tumor itself is controlled. And so I love the idea and I love the science of it. I love the hope that is behind that idea. And I think that even just patients leaning into that as they participate in these trials, like leaning into that mindset of like, well, as long as I have a chance, like this sounds like a good chance. And I can't imagine that's not going to be unhelpful, even just from a mental health perspective, like for these patients to, come into a diagnosis and learn, not only do they not have to necessarily say goodbye to their eye immediately, they have a chance to keep it, and it might actually give the rest of their body a really good shot too. So I really like that. And I think that you guys both bring really good attention to kind of the nuance of the space, right? Which is that there isn't all of the data. We don't have all of the answers yet, but we are still evaluating it. The trials are still happening, and that's a good thing. So are the trials that are happening then in the adjuvant treatment space, are they always related to neoadjuvant, or, because I know IDEA is kind of I've interviewed Darren Beaupre from IDEA before, and he talked a little about just kind of the unique way that they've structured the arm of their trials. And I know that they're going about doing that a little bit differently than most pharmaceutical companies and drug companies do, where they've got, the neoadjuvant arm, the potential adjuvant arm, and then the metastatic arm, and kind of multiple branches within that, within each of those. So that's kind of a newer way that we're seeing uveal melanoma treated in the trial space. Do we have any other, adjuvant trial treatments that are happening that you know of right now, Dr. Funchain?
That's a great question. So we have talked about before that the one FDA approval for tebentafusp or Kimmtrak has really opened up the minds of pharmaceuticals. And I actually love IDEA's approach. They've been very molecularly smart about how they're thinking about their strategies. But I will point out right now for this study, it's neoadjuvant, and then you get your definitive eye treatment, so surgery or radiation. And then there's the option to continue adjuvantly. However, there isn't a trial to continue adjuvantly.
By itself.
Yeah, by itself. So if you've already had the surgery and you haven't had the neoadjuvant and haven't been in the study, there isn't the option. And in that sense, we are very happy that they are trying to go after FDA approval as soon as possible, because we want to get this to as many patients as possible, right? It shouldn't be just you live near a trial center or you have the means to travel to a trial center. So in that way, we are with the company to just get this out to as many people as possible, right?
Yeah.
So in the adjuvant setting, there have been very few trials, I will say, again, because we didn't totally have a sense of what drugs might work. But there was a really impressive adjuvant trial that was presented at our oncology meeting. And that trial was looking at adjuvant Yervoy Opdivo or ipilimumab nivolumab. That's checkpoint inhibition. That is the traditional immunotherapy that if you look up skin melanoma, you're going to find this regimen. And they did a slightly different dosing than what we use in skin. So the Yervoy part of it, which tends to be the more toxic part of it, it was a lower dose and less frequent with the same Opdivo, but this combination immunotherapy was given after having either, surgery or radiation. And they actually showed in that study that there was about half the risk of recurrence at the 3-year mark, which is really impressive. Now, this is a small study. Whenever you do a small study, we all know in the cancer world that when you repeat it with a larger study, it doesn't turn out as you think. There are some things that are wildly positive when you do the small study, and when you go to the big study, it totally washes out. However, this is super promising. There's a big debate and continues to be a big debate. This is off-trial use. It is not FDA approved. Do you use it or don't you use it? And I will say that's very, very provider specific. I can also say that trial has clearly, because the results were very promising, that will expand to a phase 3 trial. But it is under negotiations. It is partially government-sponsored trial. With the uncertainty that is coming out of Washington nowadays, the funding for government-sponsored trials is a little bit uncertain. So we don't know, but so far the signals are that this trial will continue, and we hope it will.
Well, I think that's really promising. So if anybody wanted to look that up, would they be able to look up just some kind of generic terms like Ipi-Nivo uveal melanoma adjuvant trial?
Adjuvant, exactly. Yep.
Okay.
Yep.
All right, so that would be a good thing to search for sure. And then was there anything else? Because I know when I first was diagnosed, I was part of the Sutent and the VPA trial.
Yeah.
That was mostly headed out of Jefferson.
Yeah.
I still ended up with metastatic disease, and half the people that were on the trial with me did. It's so again, small study. What's the data? How does it help? How does it not?
Yeah.
Anyway,
Yeah, that Sutent study was very popular. There was actually a crizotinib study or Xalkori study that was very small and very popular, but very, I mean, really no signal.
yeah,
So, so those have not gone on. But those were the those were the studies we were desperately trying to get people on because there were very few spots and
yeah.
very few places that had them open. And really, there had been nothing since until this Yervoy Opdivo study. And so now we're waiting for it to reopen.
Looking at it also from the patient side, something to keep in mind is even if these studies were not positive enough to move forward, I think that as a community, we've learned a lot from them. So in a setting where we don't have options, some of the things that have come up is that how do you design clinical trials for this very unique disease, right?
Mm-hmm.
Instead of taking all comers, do we then use genetic stratification so that we put patients at highest risk into the trials rather than not including patients that are at very low risk? That might muddy the outcomes. What do we use as a control population? How do we design dosing? As much as that sounds so minute and so incremental, it's so important, right? Because when you have a rare disease, what you want is a home run with the next treatment that comes out. But sometimes you got to take some cracks at practice, hitting the ball just right. And sometimes you get really lucky up front, but sometimes it's incremental. But I think the fact, and Dr. Funchain alluded to this, that we have this interest now from the biopharma companies, and they understand that there's something unique about these tumors that are potentially addressable in ways that other tumors aren't. And for them, if they can get a drug across the finish line, as we say, meaning approved and available to patients in one disease, then they'll try to look at it in other diseases as well. So there's a lot of interest. So I think that is something that we should all be encouraging, people to be involved in trials and for better trials to come forward. And I think there are some interesting, drug candidates and molecules and trials that are coming forward from companies. And as Pauline said, go back a decade, there was there were crickets, like it was silent. People trying to do their best with what was available. Now we have, uveal melanoma specific targets and drugs that people are trying to move forward. It's a very different game.
I've got to expand that and emphasize some points that Dr. Mruthyunjaya said. He's so right on the money. Because if you think about the Sutent trial and you think about the Xalkori trial, these were the sort of great grandparents of darovasertib now, right? Of the IDEA trial now. I mean, they're all in the same family, right? They are these molecularly targeted, small molecules, and those didn't quite work. And there, and not to say just because a trial is negative doesn't mean there isn't a little bit of signal. We have seen that a lot, that there's something in there, whether you are looking at the biologic samples that come from those trials, because as anyone who's done a trial knows, they take a lot of blood and tissue from you at the same time. But there are biologic discoveries that we make from those samples, but also we just, again, it's the tweaks, right? So this is a molecularly targeted small molecule. We tried the Sutent version, we tried the Xalkori version, and actually the Xalkori version along with darovasertib, that actually is showing some promise in metastatic uveal melanoma. So actually that it was going from Sutent to this combination that actually led us to just using darovasertib alone in the neoadjuvant. And that's where we got the results. So they all build on each other.
Mm-hmm.
Same with Yervoy Opdivo. So we've all done Yervoy Opdivo in the metastatic setting. There were two different phase 2 trials, and we did a really large retrospective analysis looking at the effects. And again, while the trials were technically negative, we definitely saw signal. There were definitely some people who benefited, and some tumors that shrank on these trials. And so based on those trials that were technically negative in the metastatic setting, we then moved it and then tweaked it and tweaked the dosing and then put it in the adjuvant setting. And now we're starting to see something that's a good effect. So I think that these are these are the tweaks, right?
Yeah.
Every trial you tweak and get to something better. And now we have some really good results from trials that were done, about 10 years ago.
Well, I feel like this is a really good way to illustrate that they're all related, right? And they're all related in the sense that the treatments, we've got metastatic treatments that are happening, and most of the time when you hear about clinical trials, it's for the metastatic treatments, right? We've got the bulk of we do have far fewer clinical trials than other cancers, but the bulk of our trials live in the metastatic space. And then we have some of those that then kind of by nature or relation to other adjuvant trials, things like that, the things that you talked about. We've got the adjuvant trials that have happened in the past or that have contributed to what are we doing next and why, and just kind of the creative use of these drugs in the space adjuvantly. And then we have kind of I think the newest thing that we're hearing about is the neoadjuvant of like, oh, well, let's actually start before we treat the eye. And I think that like what Dr. Mruthyunjaya and both of you were saying is it's just so neat to see how you're connecting all the pieces and connecting them far earlier and kind of forcing the collaboration of all of these different areas of medicine, because we do have so many different doctors. You're just kind of bringing them together in a much more advanced, proactive setting, I think is maybe a good way of thinking about it.
Danae, if we could also look into the crystal ball, I think that this would also be yeah, I think we should, because I think that this may also pose a model for what we'd call precision medicine or very customized treatments for patients. So some of the work that we've been involved with here at Stanford is looking at signatures that individual tumors may possess that we can detect on taking very simple fluid samples from the eye, and we can see certain proteins that are elevated or decreased in certain tumors, and each one could be a little bit different. I mean, let's imagine a world where, before treatment, you could define what is actually active in a particular person's tumor, and with all of the techniques we have with intraocular surgery, directly deliver that to the patient's eye, right? So if you could customize, patient A has tumor type B, and that means only drug C would work. Why would you give that patient drug D or, drug F? Like that could probably fail. So I think that one of the things that we're trying to work on here is how can we use some of this clinical trial data that we have that's developing? How can we learn from that with these other biomarkers that may be available? And then ultimately, how can we come up with very defined treatments that could be very customizable? It's a stretch. It sounds like a stretch, but maybe not so much. Like there are other tumor types that's been successful in, and I feel like now, just like with people on Sutent has now led to us having darovasertib available. Everything that we've learned from previous trials might define where we can take those next bold steps going forward. So our team here at Stanford has been very interested in trying to push this, and it takes a team, right, between the medical and the ocular oncologists, our scientists, and most importantly, our patients who have been so receptive to being parts of these studies.
I think that's incredible. Is there any other areas of like the research that you guys are doing at Stanford that you're just particularly excited about, Dr. Funchain?
Oh, yeah. Yes. Yes, we do.
What?
We have actually an open clinical trial that is worth talking about. So this is in the metastatic setting. It is an injected drug called RP2. And what that does is it's injected into a liver tumor or something that you can get to with a needle. And it also then has Opdivo, so an immunotherapy, and combines them. We have seen some preliminary results of tumor shrinkage in uveal melanoma. So not just the thing that was injected, but other lesions that aren't injected will also decrease in size. The important thing to know about this trial is that it does not allow, so for those of you who are familiar with the trial space, there are a lot of checkboxes that have to be checked to get onto a trial. But one of the important checkboxes to know for this trial is that a patient can only have seen one line of therapy and cannot have had liver-directed therapy. So if there's any liver, an embolism or Y90 or any of those liver specific or DELCATH, any of those therapies, then this trial doesn't apply. So this is one of those things where they're just, again, they're trying to test early to see what they can find. I mean, I think at some point, if we see good data, this may expand, but right now that's what the trial allows for. But we've seen some pretty good results up front. And a trial that is nearby in the Bay Area and in many, many places is the trial that we just talked about, which is the darovasertib plus crizotinib or Xalkori. Both of these trials have a very similar efficacy, so they are able to shrink tumors by about 30%. So that's pretty good, or about 30% of people have tumor shrinkage. So these are some promising studies. And I think, again, as we do this, then we'll be able to tweak, we'll understand what order these things should go in. But it's really promising. I think we're having a lot of breakthroughs in the neoadjuvant, adjuvant, and metastatic areas or settings all at the same time, which is pretty fun for us. And hopefully, knock on wood, good for patients with uveal melanoma in general.
So I did have a question. Do we have any noise about yet in the use of tebentafusp adjuvantly? Like saying that, oh, we've got high-risk patients. They have a class 2, very high risk of spread tumor, and they are also HLA positive or HLA-A*02:01 positive. Therefore, we're going to put them on Tebi once a month or, once every 6 weeks, like just like some kind of a different dosing of using Tebi. Has that been noised about at all in meetings that you've been to lately?
I don't know if you've heard more recent stuff than I have, but there is noise, and it hasn't come to being yet, but we think that there might be something coming, in the future.
Yeah. Just it all takes time. And that's one of the hardest things. And I do appreciate that you alluded to, just kind of the current political climate and just what's going on in the government space that is affecting our research, our researchers, our doctors, facilities like Stanford, where they do heavy, amounts of research, and other facilities. Like we have so many fantastic doctors throughout the uveal melanoma space. And a lot of them are both doctors and they're seeing patients and they're researching. And I think Dr. Mruthyunjaya, Dr. Funchain, you guys are both in that space. And we really just appreciate all of the work that you guys are doing and just being honest and open, but also helping to bring and shed some light on, the fact that there's so much more than cricket noise that, existed 10 years ago. So I really appreciate you guys both being here.
It's a pleasure. Thank you for the invitation.
This has been great. Thank you so much, Sine.
Those of you guys listening, Dr. M wants you to know.
I want you to know that that there's a new paradigm that's being tested now in clinical studies that might allow for patients to have benefits not only to their eye, but also to the rest of their body, most importantly. The days are not as early as we think, but the data has still to show us. But I think it's opening doors for our patients going into the future. And I think we all need to be aware that there will be opportunities to be parts of these trials, and that we should all participate. And most importantly, the Byers Eye Institute is hosting our 5K event again with a Cure in Sight on July 12th. It is the best one in the whole country.
I mean,
So I'm just saying I'm not saying this. I've heard that it's the best one in the whole country. So we strongly encourage all of our patients, their families, their friends to come and celebrate their survivorship journey and to help us raise funds for this important research that's happening across the country. Here at Stanford, we share all of that back with the Cure in Sight because we want this to multiply across the country and around the world. So see you on July 12th.
I love it. Well, yes, I have been to Dr. Mruthyunjaya's 5K at the Byers Eye Institute, and Rosangel and just their whole team they are a team of superheroes putting on these 5Ks and helping a Cure in Sight, those of us in our side of the team. So thank you for that note. And also happy birthday. It's going to be a little belated for anybody listening, but
happy belated.
Yesterday was Dr. M's birthday. So we're so grateful that you are here celebrating a little bit this month with us and talking and just giving us some hope. So thank you for that. Dr. Funchain, is there anything that you feel like you would like our listeners to know, those of them listening right now?
I'm going to dovetail on Dr. Mruthyunjaya's comment. So I think that a Cure Insight is a perfect example of how much progress we make when we work together. I have to say that some of the uveal melanoma patient advocates are some of the strongest folks that I know. They have really not just weathered what they have had to weather, but have really come out to support the rest of the community. I think I have had more patients in uveal melanoma than any other melanoma talk about patient forums online and how they support one another. And, believe me, being online is tough. I understand. You hear all of it, and often you hear the wide disparities, the really good stories and the really bad stories. But I think that things like this, things like a run, things like being a part of this podcast, being part of those forums, I mean, I think everyone supports one another. And when it comes to something that is a little bit on the rare side, a little bit less known by all the doctors, except for, and the specialists, I think it's really important that everyone comes together to make these changes, make noise, help support our funding for uveal melanoma and generally speaking, cancer research. I think it's been such a pleasure to be part of a multidisciplinary field that includes not just our ocular oncologists like Dr. M, but our radiation oncologists and our patient advocates. I think we all work together. So it's been such a pleasure to be part of this community.
Thank you guys. Thank you both so much. And let's just end with the idea that you guys, let's look out for each other. Let's look out for each other. I mean, we've got our doctors looking out for our patients and for each other. And then as patients, let's look out for each other. So if you find somebody who's newly diagnosed, tell them about this podcast. Make sure that they know that they can stay up to date and that there are hopeful things on the horizon. There could be, kind of newer things that could be happening that they should know about, especially if they're newer to the treatment center or to the treatment space. And let's just, I hate to use the eye puns, but let's literally look out for each other in all the ways that we can. All right. Well, I think we will go ahead and say goodbye to our listeners. Thank you guys for tuning in. If you guys have not, make sure to subscribe on our YouTube channel. Help us get over 1,000 subscribers, and then we can start monetizing our YouTube channel. And please, please, please come to those local events that we are hosting, like the 5K in Palo Alto with Dr. Mruthyunjaya and the Byers Eye Stanford team. We're so grateful for them. We've got a couple of other really good, highly attended 5Ks happening. I think we've got a couple in Seattle, or Dr. Dalvin in the Mayo Clinic in Minnesota. We've got Dr. Stacy in Seattle, Dr. Moser out here in Scottsdale. So there are a few key locations. I do have to hand it to Dr. Mruthyunjaya though. They are the highest attended 5K ever in the history of uveal melanoma, and they have fundraised the most for uveal melanoma medical research. So if you guys want to, get in on the competition, then tell your doctors, let's get involved and let's just all look out for each other. We'll see you guys next time.